So we're going to talk about the heart part that we missed last time. All right, so did everybody get to do the FAST exam? Yeah, kind of understand the three views of the abdomen? All right, so we're going to add the fourth view, which is the heart view, okay? So I'm teaching this separate this year because, some of you guys, when you're doing, I just want you to be better at looking at the heart, all right? We're really just doing the views today, all right? We're not talking about a lot of pathology. I'm not teaching you how to calculate EF and all that kind of stuff. That'll be later in the year in the curriculum, okay? We'll go over all that stuff. Right now, we just want you to get good at getting the views while we're all here and we can help you. All right, so there are a couple of transducers. We already talked about this in the last lecture. There's the phased array or the cardiac probe, and then there's the curvilinear abdominal probe. Somebody asked me if I'm doing a FAST exam, do I switch and use the cardiac probe? When I get to that in the FAST exam, I don't switch. If I'm just doing the FAST exam, I just use the abdominal probe because I can see a pericardial effusion with the abdominal probe. However, if I'm going to look at the heart specifically and I want to have a lot of detail about the heart, I'm going to use the cardiac probe. So this lecture we're going to use the cardiac probe because that's what we're doing. We're doing the heart. So with cardiac orientation, it's a different orientation. So what's the deal with that? Why do you need to care? Well, it's not that hard to figure out, and we'll tell you why. A lot of people try and figure it out in their head to try and remember which way does the dot go, and that gets them all confused. Don't do that. Please don't do that. It's not necessary. When we were doing the abdominal exam, we were looking at I told you, or some of y'all saw, I put the probe right on top of the screen. And when you do that, you can see that the dot on the probe and the dot on the screen are oriented the same way. And then when you move that to the patient's right next to it, you just move it right over. It's all oriented the same way. All right? And it's always correct when you're doing transverse or cross-sectional imaging of the abdomen. Other direction is up towards the head. So it goes the same way it is on the screen, or the dot goes towards the head. When you do cardiac imaging, it's actually different on the screen. So all you do is orient your transducer the way it is on the screen, if you're doing transverse orientation, and then keep it the same on the bottom. So it goes the same way as it is on the screen, or towards the head, no matter whether it's abdominal, the way it is on the screen, or whether it's cardiac. Okay? You don't have to remember. You just look at the screen, hold the probe up there if you can't remember, and you go, it's the same way on the patient. Okay? Not that hard. If you happen to get it backwards, it doesn't make much of a difference, all right? Remember, if you get it backwards, the image is just reversed. It's the same amount of information. The only reason why it would make a difference is then if the cardiologist comes and looks over your shoulder, because you're telling them, hey, this echo's abnormal, then they may go, well, your image is backwards. And they may not believe that you know how to do an echo, okay? That's the only reason it matters. The other reason it matters is because pattern recognition helps you be better with that image acquisition and image interpretation, those things we talked about last lecture. It helps you with those things. So the more times you see it the same way each time, the better and faster you get. So try and follow the same way it is on the screen, but if you have to get it backwards, it's not a big loss. Now there are three standard cardiac views. Subcostal or subxiphoid, that's the same view. Just people call it different things because it's going up underneath the xiphoid or up underneath the ribs when we're imaging. Parasternal, which is up at the top part of the chest, and then apical, which is down at the apex of the heart. All right, today we're going to talk about all three, but I want you to focus on doing subcostal or subxiphoid. If you can walk away from here being able to understand subcostal or subxiphoid, you have met the goal of this lecture. I would like you to also be pretty good at parasternal long. Okay, so we're going to work on subcostal primarily, parasternal long secondarily. And then if you can do parasternal short and apical, great, but those are harder views and they're not as much information in those. So try and just focus in on one. If you get one, you've done what I want you to do. If you can add a parasternal long, that's great also. So the subcostal or subxiphoid, we take our transducer and we aim it up underneath the ribs towards the heart. Remember, the heart is underneath the sternum and out towards the left nipple, so it's right through here, and we're angling up underneath the ribs to try and image it. When we do that, we're coming through the liver, and what side, the answer is always on the screen, by the way. What side of the heart is next to the liver? The right side of the heart. Why do you know that? Because the IVC comes through the liver into the right atrium, so the right side of the heart is next to the liver, and then further up into the chest is the left side of the heart. Okay? Now, to image correctly, this is kind of a transverse view. So we do it just the way it is on the screen, and on the screen, the dot's on this side, so we orient our probe that way, and you get this view. Okay? Again, if you do it backwards, you still know right from left, not because of the right side of the screen or the left side of the screen, but because the liver, next to the liver, is the right side of the heart. Okay? So figure out one thing on the screen and figure out everything else around it. Okay? So we put our probe, our orienter, our marker's going this way, but that's not how we figure out right from left. We figure out right from left because this is the liver. So this is the right side of the heart. That makes this left side of the heart. If we look and we saw the IVC coming through the liver into the right atrium, so this would be right ventricle. This is the left ventricle, left atrium. Everybody got that? We're going to see lots of examples. The other thing we want to be able to image from the subcostal position is the IVC. The IVC tells us it's a marker of our tank, okay, how much fluid we have in our body. It's a marker of our central venous pressure. So again, it's a very useful thing when we're looking at patients that are sick, knowing whether to give them fluid or give them pressors, because we want to know if the tank is full or empty. All right, so the way we do this is we start off transverse and we see the heart, and then we turn our probe north and south because the IVC runs up and down the body. We want our transducer up and down the body because we want to see the IVC in a long axis. So the way we do this is we're transverse. Here's the IVC coming into the right atrium. We turn our probe up and down the body and slide over to the right side because it is posterior to the liver. Here's the liver. Here's the IVC. We know we're looking at the IVC because the hepatic veins are draining into the IVC. The aorta and the IVC look very similar. It is very difficult sometimes to tell the difference between the aorta and the IVC, but the way you know you're looking at the IVC is you look at the hepatic vein. The hepatic vein comes into the IVC, you know you're looking at the IVC. All right, one more time. Here's the IVC coming into the right atrium. We're cross section or transverse. We turn north and south so the dot's towards the head. Here's the heart over on this side. This is the IVC. This is the hepatic vein coming into the IVC. We're watching for collapse right at the hepatic vein, and we're trying to determine if their tank is full or empty. The next view is that parasternal long axis. Okay, parasternal long, we're up near the second or third intercostal space. That's way up on the chest, way high on the chest, and we're right next to the sternum. So we're very far up. Now, just pay attention for a second, all right? Watch me. So if I was going to put my hand where my heart is, I'd put it like this, right? So the IVC comes into the right atrium, and then if you feel for your PMI, you can feel your PMI. That is your tip of your left ventricle. So I put my fingers at the tip of my left ventricle. My heart is laying like this. Does that make sense? All right, so if I'm going to go dot to the head, I'm not getting a long axis view of the heart, am I? No, because the heart doesn't lay up and down my body. It lays a little off to the side. So when I turn my probe so that I have a long axis view of the heart, it's not going towards the head. It's going towards the shoulder to give me a long axis view. Does that make sense? And if I turn 90 degrees, it gives me a cross-sectional view, a CT scan slice of the heart. Does that make sense? So it's generally towards the head, but if I pointed it straight to the head, it wouldn't be a long axis view. And this is a long axis view, parasternal long. So we turn our probe a little bit more towards this shoulder and it gives us a long axis. If I had a lot of COPD, a lot of emphysema, if I had a lot of emphysema, my chest would be expanded, my heart would be hanging like a sack, wouldn't it? So then it would be a little bit more straight up and down. If I had chronic bronchitis and I had decreased lung volumes and it was way over flat, it would be really pointed across, right? Does that make sense? So I want to, once I find the heart, I'm going to scan around, I'm going to stick the transducer up here, I'm going to look around until I find an image. Remember, you can't see through air. Remember, that's one of our images. So I'm going to scan around until I see something that looks like the heart. So I see something. And then I'm going to adjust my transducer so I have a long axis view of the heart. Now with the parasternal, you don't see the right side of the heart. Okay? We're not going to use a parasternal view to look at the right side of the heart. Parasternal view is for looking at the left side of the heart. So we're making the left side of the heart in long axis. So here's the left ventricle in long axis. This is the left atrium. Between them is the mitral valve. This is the left ventricular outflow tract. So this is the aortic valve and the ascending aorta. This is the right side of the heart. We don't see much of it. Okay? So if we're looking, using a parasternal view, remember, I told you that we were looking, the right side of the heart is next to the liver. It's way down here. We're looking up here, way up high in the chest. We're not looking at the right side of the heart. We're looking at the left side of the heart. So this is the left side of the heart in long axis. Back behind the heart is the spine, bright and shadowing behind it. and right next to it is the descending aorta. So the aorta comes out of the heart, loops back over, and comes right down the spine to go into the abdomen, right? So that's the descending aorta in the back. So let's see what that looks like in a video. So here we are, we're kind of angling this way, all right, because we want a long axis view of the heart, all right? And so when we do that, here is the left ventricle in long axis, the left atrium, the mitral valve, the aortic valve, the ascending aorta, looping back around, here's the spine, here's the descending aorta. Everybody got that? Notice you don't see much of the right side of the heart. This is actually the right ventricular outflow tract, but we don't use it to look at the right side of the heart. Not traditional. Okay, so everybody see the left ventricle? See how well you see it? Remember what were our enemies of ultrasound? Air, bone, and what was the other one? Distance. When you come subcostally, you got to go all the way through that liver so you don't get a lot of detail because distances are enemy. Here, you can get this view on almost everybody. He's a little low up here. It should be a little bit up here. You can get this view because the left ventricle is really close to the skin surface. So see how well you see the endocardial border, the mitral valve, the papillary muscles, all of those details? Because this is a high-resolution view. That's why we use it. Now, if you go from this view, remember we're pointing off towards the shoulder. If we rotate 90 degrees, we get a cross-sectional view of the heart. So we get a cross-sectional view, a CT scan slice. So this is a nice view when you want to see all the walls of the left ventricle at the same time. And we like to do that when we're looking at wall motion abnormalities because we can see if all the ventricular walls are coming in towards the center to tell us if one of them is not working well. All right, so this is a nice view. So we go from one view, we're kind of going this way, we get a nice long axis, we turn 90 degrees. When we turn 90 degrees, we go from a long to a short. See, it's a nice circle. This is the fish mouth mitral valve. Now we're down in the papillary muscles. Now we're down in the ventricle. We can angle back up towards the base of the heart. Now we see fish mouth mitral valve, and then we come up into the aortic valve. Okay, we can see different slices of the heart, all right, because we're moving our transducer. And really what we want to see is a nice circular cross-section of the heart down in the ventricle because it helps us see the septal wall all the way around, and we can look to see if the walls are all coming in towards the center, right? And it helps us know which wall is abnormal. So we use this one to help us know if there's a wall that's abnormal. Remember, in Parasternal Long, we're only seeing two walls, right? The septal wall and the posterior wall. Here, we see the septal wall, the anterior. You can move it like a clock face and go around the outside of the heart and know, okay, this wall is not moving in, so that means that the septum is abnormal, okay? Or this side of the heart is not moving, so this is the anterior lateral part of the heart. Does that make sense? Here we are. We got a cross-sectional view of the heart, the papillary muscles. So we know this is the septum because this is the right side of the heart, this is the left side of the heart. So we can look and see this must be the septum, and then we can go around the clock face to determine if any of these walls are abnormal. We can look to see they're all moving in towards the center. Right? See how you use that view? All right? Now let's talk about the apical view, which is a less important view. This is the one I want you to work on the least. All right? I want you to work on the others more. All right, this is a harder view to get, and it's often hard to get in sick patients because you really need to roll people into the left lateral decubus to move their heart closer to the chest wall. Can't do that in a lot of people, so this is the one I want you to rely on the least. However, it is a very, very informative view because you get to see all the chambers of the heart at the same time. So that helps you know if one of them is abnormally large. That can be very useful when you're detecting an acute PE. It also helps you look at the EF very well. It also looks right down the barrel of the left ventricle so you can detect if there's a mitral regurgitation or stenosis very well, as well as tricuspid. Very useful view. More difficult to get than the others. So we don't, I don't want you to spend a lot of time on that today. We will do this later in the year where it will become easier. So this is the least important view. But when you do it right, this is kind of a transverse view of the heart. So the dot goes the same way it is on the screen, so it's going towards the bed, towards his left side, just towards the bed. And if you put the probe right on the PMI, this is a little bit off the PMI. If you put it right on the PMI, you will look right down the barrel of the left ventricle into the left atria, across the mitral valve. And this is the right side of the heart. You're looking across the tricuspid valve to the right atria. Does that make sense? Does everybody understand anatomy? Everybody is going yes. So let's try that out. Let's see if you really do know the anatomy. All right, so I'm going to give you random views, and you're going to tell me what view I'm doing and what the anatomy is. Okay, so this is the Liver. So when we look at this, what view are we using? Subcostal. So this is which side of the heart? Right side of the heart. That means this, the what side of the heart? Left side of the heart. Look at the endocardial border. It's really hard to see because remember, distance is our enemy. Do you think it's beating well or poorly? Poorly. So if this was a code blue up on the floor, do you think that they are doing well or poorly? They're doing poorly. They don't have a very good EF. They don't have much contractility. This is the IVC. All right. Do you see the heart beating? No. What do you see in the IVC? Blood clots. So do you think this patient is alive or dead? Dead. Why is the blood moving in their IVC and hepatic vein? Because you are ventilating them with a bag valve mask. They're intubated. So that's the thoracic pump moving the blood back and forth. But their blood's clotted off, so they are dead. Does that make sense? Everybody see how to do this? This is a fun game? All right, let's keep going. All right, so what view are we looking at where we're at the tip of the left ventricle? Apical view. We're looking down the left ventricle into the left atrium. Everybody see that nice endocardial border there? It's a little harder to see over here, but you can see the septum really well. Everybody got that? You can look at the size of the chambers. What's the largest chamber in the heart? Left ventricle, then the left atrium, then the right atrium, and then the right ventricle. The right ventricle is the lowest pressure, smallest chamber in the heart. Does that make sense? Good. And that's in the normal person. All right, so we're going through the liver. So this is which side of the heart? Right atrium. This is the IVC coming into the right atrium. Everybody see that? So you can tell right from left, no big deal. Let's look at the IVC. Here's the hepatic vein. We watch for collapse when they breathe. If it doesn't collapse, then that means their central venous pressure is high. That means their tank is full. If it does collapse, or if the IVC is real small, then their central venous pressure is the opposite. It is low, right? And they need fluid. So you can look at the left ventricle, which just went off the screen, and you can look to see if their EF is high or low, and you can look to see if their central venous pressure is high or low. So here's the left ventricle. Is the black space disappearing? It's a little hard to see. But the black space was disappearing, so does that mean their EF is high or low? High. It's very high. And their central venous pressure is high or low? High. So here's a patient in shock. Their blood pressure is low, but their heart is beating hard and injecting all the blood it can. Their EF is very high, and their tank is full. So I'm not going to go into what that is, but you can think about what is the pathology that would do that. It's a tough one. Maybe you can come up with it. All right? Here we are. We don't see much of the right ventricle, but we see a lot of the left ventricle. What view is that? Parasternal long, because we see all of the left ventricle. What's this? Left atrium. What's this? Mitral valve. What's this? Aortic valve. What's this? Ascending aorta. What's this thing? Spine. What's this thing? Descending aorta. Very good. All right. We're looking down the barrel of the left ventricle. What is this? Aortic apical view, right? And look at the endocardial border, right? Does that look like a normal EF, a low EF, or a high EF? It's normal to low. It's a little bit on the low side actually, so it's a little depressed, but it's pretty close to normal. Look at the chamber sizes though. This should be the biggest chamber. Look at that chamber. Do you think that that is big, or do you think it's normal? Big. It's too big. All right. See how you use the apical. Now we're not going over all of this and why, but this is why you use the apical view. It's really nice. All right, what is this? What view? Parasternal short. You're looking into the ventricle. Here's the papillary muscle. So what is this wall here? Septal wall. And then we go around the clock. Anterior, lateral, back to inferior. Make sense? Yes.
Did that last one have a pericardial effusion? And if not, what was that?
Make it play.
No.
Let's make it play. So right here?
No, further outside.
Further outside,
Yeah.
right? Yeah, so there's a slight pericardial effusion. Slight pericardial effusion. All right, so everybody see all the walls moving in towards one another? That's parasternal short. That's what we use that for. All right, what about this parasternal short? Here's the papillary muscle, here's the papillary muscle. Really hard to see that wall, but you can see a little bit of the septal wall. What do you think? The EF is normal, low, or high? Low. See how you can do this? You can do this. This is easy stuff. All right, back to this one. This is apical, looking down the barrel. EF, low, normal, high. You already answered this because I asked you too quickly, but it's on the low side of normal. What about this? Is the central venous pressure low, normal, or high? Low. Why is it low? Because the IVC is small and it's collapsing when they breathe in. Everybody got that? What about in contrast to this one? Is the central venous pressure low, normal, or high? High. Why is it high? Because it's a big dilated IVC. You can even see the hepatic vein is dilated, and it doesn't collapse with respiration, so the central venous pressure is high. Everybody got that? That's easy stuff? Easy stuff, right? What about this? This is what? The liver. This is the heart. Which side of the heart is this? Right side of the heart. Which side is this? This is which chamber? That's not a chamber? No, it's pericardial effusion, right? So I couldn't give you a lecture and not tell you some clinical kind of stuff, right? It's not just about views. So this is the pericardial effusion, right? Everybody agree? Right? So what do we look for when we see a pericardial effusion? We look to see if it's tamponade, right? So a pericardial effusion can be its own diagnosis, and that can be part of why the patient came in. Let's say they have pericarditis and they have an effusion problem. But most of the time we're looking to see if they have a hemodynamic effect or a pending hemodynamic effect, which is pericardial tamponade, right? So how do we know the difference between pericardial effusion without tamponade versus pericardial effusion with tamponade? Because remember, the pericardium is a relatively fixed space. So the more blood there is in the pericardium and not in the heart, the less blood there can be in the heart. And so the heart doesn't fill. If the heart doesn't fill, it can't eject blood, so the blood pressure falls, right? That's what tamponade is clinically, right? So the more fluid there is in the pericardium, the less there can be in the heart, the blood pressure falls. If it's a fast process, then it takes just a very little bit of blood, and you start having hemodynamic effects. If it's a slow process like the dialysis patient that starts getting uremic, start getting the pericardial effusion, it can be a slow process. The pericardium can actually dilate. It can be a lot of fluid, and it not be any hemodynamic effects. Everybody got that? Right? So small doesn't always mean not bad, and big doesn't always mean bad. All right? So we can't use the size of the pericardial effusion to tell whether it's tamponade or not. The way we do this is by some definitions. Does anybody know the book definition of pericardial tamponade? Somebody's got that book definition. The Echo book definition. Collapse of the right atrium during diastole. So during diastole, the right side of the heart should be filling with blood. And if it can't fill with blood, that means the pressure inside the pericardium is too great and the right side can't expand. So here's fluid in the heart, and the pressure is so great that the right side of the heart can't expand. Everybody see that? It doesn't fill with blood. If it doesn't fill with blood, it can't send it to the left side of the heart, so your blood pressure falls. Does everybody got that? Pretty easy to see. All right? So the definition is of tamponade by ultrasound is that the right atrium has late diastolic inversion, collapse, and the right ventricle has early diastolic collapse. Okay? But that is pretty difficult to see, all right? So what I would rather use is the IVC and make a determination if it's starting to be tamponade or if it is tamponade. Now let me tell you why. This is very difficult to see. Here's a patient that has RV collapse during diastole. All right, you know that because it says it, right? That's how you do it. But if this was beating, how do you know where diastole is and systole is? Does anybody know how to tell on an echo? You can look at the valves. Yeah, so the valves actually is the correct answer. But really the way they do it is most echoes you see have the EKG tracing down here. And so you can slide until you see the end of, you can use the QRS to know whether it's systole or diastole, and then look to see if the ventricle or the atria are filling. Now, you can look at the valves to know the difference. But what if you had a heart that looked like this? It's hard to see the valves, right? I can't see the valves, right? Is this tamponade? I already told you it was because the right ventricle is not even filling, right? It's not filling any time during the cycle, so you don't need an EKG to know whether this is filling or not. It's not filling, so that's tamponade. Everybody agree? Right. Well, what about if you had this? This, I can't see the valves really well. I don't have an EKG. See, my EKG is not hooked up. So is this tamponade? This is actually a patient who got stabbed in the chest, so this is blood in the chest, right, from a stab to the heart. So is that tamponade? I can tell you it is because it got coded and died, all right? And this was early tamponade, and by the time they got back to the CT scanner, it was late tamponade, and their blood pressure had already fallen, okay? So it's hard to tell whether there's diastolic collapse because you don't have all the tools to tell, all right? What about when you got a heart like this? What view is that? I don't even know what view it is. I know it's subcostal, but it's hard to tell because nothing is normal as you see it. So where is the right ventricle in this mess, which is this huge pericardial effusion, right? This is probably a dialysis patient. Where is the right ventricle versus where's the left ventricle? Well, this is the left ventricle. This is probably the right ventricle. So how can they even tell if there's diastolic collapse when I can't even see it very well? All right? See what I'm saying? Can be a challenge. So if you look, diastolic collapse is actually a fairly poor sensitive, and when you're looking at sensitivity, it's pretty poorly sensitive for detecting tamponade. IVC being big and dilated is pretty sensitive. The problem is it's not really specific. So if you use the IVC, you have a very high negative predictive value, which is what we want to know, right? We want to be able to rule things out. So this is a high negative predictive value. That's a good test for us. So if we get this patient, here we are, subcostal, here's the heart that we saw it before, we've got pericardial effusion. What do we want to look at to tell if it's a pericardial tamponade or if it's approaching the pericardial tamponade? The IVC, all right? So remember, your clinicians first, sonographer second. So patient comes in, they are hypotensive, they've got distended neck veins, they got muffled heart tones, all those things that you read about. You look with ultrasound, they got pericardial effusion. What should their IVC be if they're in tamponade? Big and dilated, right? Should be big and dilated because the fluid should have a hard time getting back into the heart. If you see a collapsed or small IVC, what is it tamponade? Can it be tamponade? No. That doesn't fit, okay? So you see how to use this clinical scenario with your ultrasound knowledge to build that clinical picture? Everybody got that?
How about if they're in hypovolemic shock?
Hypovolemic shock with a pericardial tamponade.
No, not possible.
Well, it can happen. It can happen. Yeah, sure it can happen. You know, you got stabbed in the heart and also got shot in the belly at the same time. You just in a world of hurt. That's what you are. You're just in a world of hurt. So anyway, this is just a quick introduction. We're going to do more of this cardiac stuff, more advanced cardiac stuff later. What I want you to do is go next door, try and get the subcostal. I want you to make very good subcostal pictures, subxiphoid pictures. Once you get that done, then you can move on to parasternal. Remember, parasternal is up high in the chest, not down low in the chest. Up high in the chest, try and make that long axis. And then you can finish up with apical if you want to. Okay? All right, everybody move on.